I'm Dr. Rachel Coleman, and I am excited to bring to you a new health education program. Our goal is to educate and empower you in regards to your health so you can live a productive life. We're not here to diagnose any particular medical condition. You need to see your own personal physician for that. February is Heart Health Month, and so we're going to talk about the heart. First, we're going to stop by the American Heart Association, the Cincinnati division, and talk to the director of the Go Red for Women movement. Later, we'll talk to Dr. Joe Hackworth. He is a phenomenal area cardiologist. He's affiliated with all the hospitals, a lecturer, and a phenomenal teacher. He's going to share with us about the heart. And then we'll also stop by and see Terry and Maria. Terry is a phenomenal personal trainer, and she's going to educate us about fitness. So stay tuned. Can you tell us about the campaign and what it's all about?
Sure. So the Go Red for Women campaign movement, as we like to call it, was created about 12 years ago by the American Heart American Stroke Association to really bring awareness and spread education around the fact that heart disease is in fact the #1 killer of women and all Americans. And when we first created it, it was really because so many women were going to the doctor complaining of symptoms that were in fact heart disease, but being told that it was something else. And then unfortunately losing their lives to a heart attack or a stroke of something that could have been prevented. So this campaign, this movement, is a national thing with the Heart Association. And here in Greater Cincinnati, we have the 4th largest campaign in the country. I'm very proud of that. And it's a group of very, very passionate women, but a lot of men as well, that believe that prevention is a huge thing. Spreading awareness is just the key to preventing, actually, and just preventing death in general from this awful disease. And really, since we started Go Red 11, 12 years ago, we've seen a huge, huge impact. More than 500 women per year are being saved in Greater Cincinnati because of the message of Go Red. And that really has a lot to do with the fact that, people know that it's the #1 killer. They know that the signs and symptoms are different for women than for men. And so that's really what it's about.
So, good day to everyone. This is February 2016, and this is Heart Health Month. And we want to spend some time talking about heart healthy activities, hopefully impart some new ideas, and get some stimulation on how we can get ourselves healthier and in better conditioning for the new year. I am a cardiologist. I'm an interventional cardiologist, which means that I take care of people who are having heart attacks and try to stop heart attacks from occurring. And we'll talk some more about that. So February being Heart Health Month, we want to get into the realm of looking at prevention and detection and, of course, treatment. And hopefully we'll get ourselves in better condition as we go forward. So when I look at my heart patients, I look and try to classify them into one of 5 different categories. And I look at the idea of coronary disease, which is one of the bigger pieces of what I do in taking care of adult patients with heart disease. And that in the coronaries are the arteries that supplies the heart muscle with blood. And what happens when we have a heart attack, one of those arteries becomes blocked, and thereby part of the heart muscle gets no blood supply, and thereby we start the process of having a heart attack. And we'll talk some more about that. We have patients who do get muscular disease. So remember that although we look at the heart as being the seat of all of our emotions, and when we get excited or nervous, our heart goes faster, it is simply a muscle, and it is a pump. And so the pump takes in blood, and it pumps out the blood. So when the heart contracts, it pumps out the blood. So we have problems sometimes with what we call muscular disease, where the muscle becomes damaged in some way or another. The most common reason why the heart muscle becomes damaged is with a heart attack. We block off an artery, the piece of heart muscle dies, and therefore a piece of our heart function dies, and that's why the heart goes bad. There are viruses that attacks the heart muscle and makes the heart muscle weak, and we have people who have what we call cardiomyopathies with that. Cardiomyopathy means cardio means heart, myo means muscle, and pathy means disease, cardiomyopathy or heart muscle disease, and we deal with that. Then inside the heart there are 4 valves. These valves are like doors that allows the blood to go from one chamber to the next chamber to the next chamber. And most of you will remember that there are 4 chambers in the heart, and so the blood goes through one valve, through the next valve, through the next valve. Sometimes over time the valve becomes compromised. It doesn't open properly, we call that stenosis, or the valve does not close properly, and we call that incompetence or insufficiency. And there are times when we have to go in and fix these valves, either replace the valve with another valve or use a method called balloon angioplasty or valvuloplasty, where we blow the put a balloon in and basically inflate the balloon and open the artery that way, open the valve that way. Then there are patients who have what I call electrical diseases. If you have ever had an EKG, you will remember that what we're measuring is the electrical activity of the heart. We see these little waves blipping up and down. That means that there is electrical activity, and we're measuring that. So there are people who sometimes develop electrical problems of the heart, and electrical problems would be may need a pacemaker. So we implant pacemakers for those purposes. And then outside the heart, there are what we call the great vessels. These are the vessels that takes blood away from the heart and brings blood back to the heart, and we sometimes get disease from that. So this is a cartoon looking at a schema of what the heart looks like. And just to bring you up to snuff, this silhouette would be the heart. This silhouette would be the coronary arteries, the left coronary artery and the right coronary artery. And when the heart contracts, it pumps blood through the aorta, up the what we call the ascending aorta, and then the transverse aorta, and then the descending aorta, in that fashion. Taken off from the aorta, there are the subclavian arteries. This one goes to the right arm, and then this one goes up to the right side of the head, up here, and then the left arm and the left side of the head. So, and then as we go down the body, we have vessels that goes to the stomach and to the intestines, and then with this vessel goes to the kidneys. You can see the outline of the kidneys, and then of course as it goes on down to both the right and the left leg. We want to look at cardiac risk factors, and this is one of the things I do talk to my patients about with regularity, and we try to go over all these things. This list of things, or the list that we find, increases the risk of coronary and heart disease. Age, obviously, as we get older, is more likely to occur than in younger people. So, and that's something that we cannot change. Gender, men are more likely to have disease than women. I guess we can change gender. Bruce Jenner did it. And then family history, we can't change that. So these in black are the ones that we really can't change very readily. The ones down here are the ones that we work very hard trying to get people to do behavior modifications and change. Weight, the BMI going up pretty high, puts us at increased risk. So we try to get people to lose weight, get into a better shape. Blood pressure, we've been talking about this for years and years, and we do know what we should be doing about trying to control blood pressure. And we have shown over the last 20, 25 years that controlling blood pressure makes a big difference in terms of our risk factors. It reduces our risk factors fairly significantly. And then cholesterol. We've been measuring cholesterol for many years now, and we try to get what we call the good, the bad cholesterol into a perfect order. We want the good cholesterol higher and the bad cholesterol lower, and people do better when we can do that. And we have shown that by lowering bad cholesterol, we're able to reduce the risk of heart attacks and reduce the risk of recurring blockages around the heart. Diabetes is an important contributor to cardiac risk factors, and uncontrolled diabetes places us at higher risk. And so today we're measuring not only the blood sugar, but we're also measuring what we call hemoglobin A1C, which gives us an average of what the blood sugars have been for several weeks. And we try to get that into better conditioning. Smoking is a major contributor to coronary disease. My patients in Kentucky who smoke very heavily get much more disease at a younger age than people who don't smoke. So we try to work on that. And of course, activity and being sedentary puts us at some bigger risk, and that feeds back to the weight and trying to get the weight down. Common terminologies that we look for in treating and dealing with patients would be heart attack. I had this one lady told me that she had 25 heart attacks yesterday. And so her definition of heart attack is a bit different than our common definition in medicine. And so we try to identify to that patient what a heart attack is. And a heart attack, in my estimation, is when an artery around the heart becomes blocked and it shuts off the blood supply to a piece of the heart muscle. And that piece of heart muscle starts to die. That is what we call a heart attack. Not every chest pain that we have, we don't call those heart attacks. And so our goal always is to try to prevent those arteries from blocking, and hopefully we can prevent heart attacks. Congestive heart failure is one of those conditions where the heart has become damaged in such a way that it's too weak to pump blood sufficient for the body. We need a certain amount going to our muscles and our legs or the brain so that we can function properly. And when the heart becomes weak enough, it does not pump enough blood, so we get tired very easily. Our legs get tired. Our brain does not work as well. We become more short of breath. And sometimes we don't pump enough blood to the kidneys so we can get rid of extra fluid, and that fluid builds up in our bodies, and when it builds up into our sufficiently enough, we have foot and leg swelling, ankle swelling, and we get blood into fluid into our lungs. We can't breathe so well. It's like drowning inside. Blood thinners. These don't thin the blood per se, but what they do is reduce the clotting ability of blood. If you ever got kicked or cut, at some point your blood has to clot so you won't keep bleeding. So we use blood thinners to help prevent blood clots from developing in our bodies and our body parts. And there are different kinds of blood thinners that we use these days. Blood pressure pills. Most of the medicines we use for treating blood pressure on an outpatient basis are pills. We do have a patch that we can use, and that's been pretty nice for some patients. It helps some patients. And if you're in the hospital, then we have intravenous blood pressure medications. EF, or ejection fraction. Every patient who sees me these days has an ejection fraction determination. An ejection fraction is a measure of how strong the heart is pumping. So when the heart contracts, it never pumps out all of the blood. If it did so, that would be 100% ejection. So the heart never does that. But normal should be around 50 to 55% ejection. So the heart pumps out a little bit over half, or about half of the blood with each pump, which means that about half the blood remains. So when someone tells you your ejection fraction, if it's 50% or higher, you're within normal range. If it gets up to 70 to 75%, that's really pretty good. When it drops down below 50%, that means your heart is weaker for some reason or another. And when we get down to 10%, that's really a very, very weak heart, and in some estimations may be incompatible with good life. So we try to improve that, and we try to know what the ejection fraction is. There is a condition called atrial fibrillation, or some people call it AFib for short. And you've probably heard a lot of stuff in the news recently about people with atrial fibrillation. The importance of atrial fibrillation is that it is an irregular heart rhythm, and the very important part about it is that people who are in atrial fibrillation might have an increased risk of blood clots inside the heart. And if you have a blood clot inside the heart, there's a risk that that blood clot can travel from the heart to someplace else. If it goes to the brain, that means stroke. And so when people are in atrial fibrillation, we try very hard to get them out of atrial fib back to a regular rhythm. If they remain in atrial fibrillation, then most people do get blood thinner medicine to keep them from clotting, so we can reduce the risk of stroke. And in the last 15 or 20 years, we've seen a dramatic reduction in the risk of strokes because we treat people with atrial fibrillation with blood thinner medicine, anticoagulants. And then there's a term that you might hear called dual antiplatelet therapy. That means dual means two. And when we have people who've had a heart attack, our risk of having another heart attack is higher than normal, And so we use medications to help prevent the blood clots from occurring inside the arteries, and that's called dual antiplatelet therapy, and we can talk some more about that. So this slide basically shows what happens when someone has a heart attack. This is a still frame of someone's coronary artery. The artery is around the heart. You can see here where, in this view here, the artery is completely blocked. Blood goes in, but it stops right there, okay? So this is a heart attack that's just happened, just occurred, and we go in and we do a balloon, we open it up, and we improve, we reestablish blood flow down the artery and hopefully prevent that piece of heart muscle from dying. We do know that we have a short window of time to get that artery open. So if you have a heart attack, you go into an emergency room anywhere in this state, you're going to be asked to go to the cardiac cath lab, no matter what time of day or night it is, to get a procedure. And the procedure is to do an angiogram to find out which artery is blocked, and then with the opportunity to open that artery. And our goal is 90 minutes from the time a patient presents to the emergency room door to having that artery open. And we know that if we can get that artery open within 90 minutes, we have a very, very good chance of preventing the heart muscle from being damaged. And so we got to live for the rest of however long we're going to live, and you do better if you have a fully functioning heart than having a piece of your heart muscle dead. So what to do? We try to get all of our patients to do what we call take an assessment of themselves, whether they be 60 years old or 80 years old or 90 years old. Where are you now? We know that so many years have gone by, and so do we have blocked arteries? Do we have issues that we need to address, and how can we improve our conditioning and improve our risk factors for the future? We push for dietary modification. We're trying to get people to have much better lipid profiles and get their cholesterol numbers in better shape. Get better blood pressure control, get lipid control, stop smoking, and increase physical activity. And on this next slide, we talk about know your numbers. So your blood pressure. We should have a blood pressure somewhere around 120 over 80. That's been what we call normal for many, many, many years. And if we can get to somewhere near those numbers, then we're in pretty good shape. Now, we have to recognize that the blood pressure is not a static number. It doesn't stay the same all the time. It goes up and down depending on where you are in your day, depending on how much activity you have in your day, depending on how much stress you have in your day, depending on how much pain you have in your day. So, but as a benchmark, 120 over 80 is about where we want to be, somewhere near that. Recently, the Heart Association and the American College of Cardiology have relaxed some of the requirements on blood pressure so we can drift up to 140 and be okay, 190 over 95. So somewhere around 120 over 80 is where we should be, and in that range. We try to get people to know what their A1C is, and their hemoglobin A1C refers to what their blood sugars have been over a period of time. If I take a blood sugar from anyone at this point in time, it will not be a reflection of where they are, because if you just had a meal, your blood sugar will be higher. If you just drink a Coke or some kind of fruity drink or something, your blood sugar will be higher. But it doesn't reflect what your sugars have been on an average. So we try to get the hemoglobin A1C. It should be less than 7. We need to know what our cholesterol numbers are. We look for a total of somewhere around 180 to 200, and we measure what we call the HDL, which is a good cholesterol, and we measure the LDL, which is the bad cholesterol. And the LDL, for most people who don't have heart disease, should be under 100. My patients who've had heart disease, who've had a heart attack, who've had blocked arteries, who've had a stent, who've had bypass, we target them at around 60. So we're much more aggressive in those people who have known coronary artery disease. The HDL, the good cholesterol, should be around 40 or greater. And of course, we try to get people to know what their BMI is. And there are charts that we can use based on height and weight. And we're trying to get people who have BMIs of 25 or less. That would be kind of ideal. Most Americans are higher than that. And so, know your numbers, kind of keep an eye on your numbers, ask your doctor what your numbers are, and then ask your doc what kind of strategies can you use to achieve those numbers. That's my take for Heart Health Month for 2016. Thank you.
So we're going to show 3 exercises using your body as the weight. It's going to be your resistance. We're going to start with a lower body exercise using large muscle groups. That's going to increase your calorie burn. The larger the muscles that you exercise, the more calorie burn you get. So today we're going to use the chair. If you have mobility issues, this is an easy way for you to start getting stronger in your lower body. So Maria's going to demonstrate the sit and stand. First, Maria, I just want you to separate your feet about the width of the legs of the chair. And all you're going to do is stand up. You're going to drive through your heels and come to a standing position. And when you sit back down, you're going to drive back through the heels and have a seat. Lightly touch, come back up. You want to do 8 to 10 repetitions and then do a second set as you get stronger. How does that feel, Maria?
Feels great.
Feels good? Where are you feeling it?
I am feeling it definitely in my thighs.
And thighs?
And my glutes.
Perfect. So the glutes are the booty and the front of the legs, maybe even some hamstrings pushing through the heels. Perfect. Okay, we're going to go to our second exercise. That's going to be an upper body exercise as well as using some of our core muscles. We're going to go to the wall and do a push-up. Everyone has heard of a push-up? Maybe you've done a push-up in the past. Maybe you have attempted but didn't know exactly how to do it. So we're going to use the wall. Again, if you have mobility issues, you can use things around you. So Maria, put your hands on the wall about chest height. You're going to come back a little bit. Perfect. You're going to keep your body in a perfect straight line as you bend your elbows and bring your nose towards the wall. Now, if you can't bring your nose all the way to the wall, that's okay. Just start bending the elbows. It's going to work the chest. Go ahead and show us. You're going to use your arms, your back. She's using her core. Her belly is tight. She's exhaling as she pushes away, inhaling as she comes forward. And you want to do 8 to 10 repetitions. One more time. Perfect. Tell me where you felt that.
I felt it in my arms and my chest.
Good. Excellent. So the last exercise we're going to demonstrate today is called a plank. That's going to be a core exercise, and we're going to go over here to the floor to do it. So now Maria's going to demonstrate a plank. That's a core exercise. It also incorporates some upper body, so you can increase the strength there as well. We're going to have 3 different levels. We're going to start with the most basic and make it a little harder as you go. If you can't get on the floor, you can do this in your bed. So there's no excuses not to do it. So Maria, let's come on down onto your knees, into a full arm, and just keep your body like a full plank. Now lift your hips slightly and pull your belly button in. Neck is in line with the spine, so look straight down. Yep, perfect. And you want to deep breathe. So this is your basic plank movement. This is a timed exercise. You want to build up. So let's say you can do 10 to 15 seconds. Build up to 30 seconds and increase from there. The stronger your muscles get, the more endurance you'll have, so you'll be able to go a little longer. Okay, are you feeling that?
I'm feeling it.
Great. So now we're going to go to the second level. Down onto your forearms, toes on the floor, and lift. Again, head in line with the spine, so looking straight down. Perfect. Abs are in nice and tight. Maria, are you feeling this?
I am feeling it.
She's feeling it. She's going to have some rock hard abs when we're done.
I better.
And go ahead and relax. Drop your knees. And the last level is going to be the hardest level. Obviously, you're going to start with the beginner and move up as you get stronger. So let's go into our last level. Full arms, up on the toes, head in line with the spine. Perfect. Abs in, deep breathe. And she's pushing through her arms. She's using her legs. She's using her abdominals. And Maria, are you feeling this one?
I am feeling it.
This is great. Okay, and relax. Perfect. Well, I want to thank Maria today for an awesome assistance and all the exercises. High five. And thank you for joining us for our basics and exercise 101.
Hopefully you now know a lot more about the heart than you did when the program first began. And hopefully you are also feeling educated, empowered, and maybe even inspired. That's the show for today. Before we leave, I'd like to thank Dr. Joe Hackworth for his excellent presentation on the heart. I'd like to thank our friends at the American Heart Association, Jenny Kramer and Lori Fovell, for allowing us to come, and thank them for sharing. And I'd like to thank Terry and Maria for the fitness segment. And I'd also like to give special thanks to FitWorks for allowing us to tape on location. So again, that's all for now. So until next time, I wish above all that you prosper and be in health.